next one is definitely going to captivate you. Our next is a Fireside chat, Integration and Interoperability, Enhancing Safety and Seamless Data Exchange in Mobile Health Ecosystems. Sounds pretty technical, right? But don't worry, we've got a stellar lineup of experts that are here to break it all down from us, from tech advancements to regulatory policies and actionable tactics. They'll be sharing insights and strategies that'll leave you feeling empowered and informed about the mobile health landscape. I'd like to welcome to the stage our two speakers. We have Shikha Kumari, the Deputy Director of the National University Health System of Singapore, and Mr. Vivek Mahendra, the Managing Partner of Viveka Advisory. Please put your hands together for our speakers. You're very welcome. Yes, mic's on the table.
I think it's on. Yeah, hi. Thank you, Maxim, and thanks to all of you who are staying back. I think I'm standing between you and the lunch. Me and Vivek will try to give you some pointers which will be interesting and share some of our perspective. So I am from a provider side. I am from one of the 3 health clusters in Singapore, taking care of or implementing value-based healthcare. And our cluster has 3 acute hospitals, 2 step-down hospital, and few poly clinics. So I will be talking from the provider side and the patient side. And then we have Vivek.
Yeah, good morning, and I hope you're having a good day here. So I come from, you may call it the consultant influencer, to see if how we drive affordability and accessibility for healthcare. For the last 15 years, I've been working with provider ecosystems in the US and in India to see how we bring data interoperability in a way that helps from a longitudinal health perspective and see how it leads to maybe more accountable outcomes. What I will try to do is to not go technical on this subject, because the subject can really become technical in nature, but focus on bringing in a few elements for thought here. Because I think what we need is a more cohesive thinking process in this, and especially because it's a fireside chat, I hope it doesn't burn us. But some of the thoughts we intend to put up here are thought-provoking and a little more inclusive, and we hope that we'll get your support through the process.
Thanks, Vivek. So I think we do have a clicker, or there are a few slides we have just put as a backdrop.
Move the slide, please.
Yeah, next slide, please. Yeah, yeah, thanks. So,
I'll pick it up.
Yeah. So basically, before we get into the topic of this fireside chat, which is interoperability and integration, and mainly from the data point of view and the mobile ecosystem. But before that, we get into a bit of where we are and what we have and what we need to do. We wanted to set the context, what we are seeing right now. So we are at the time where we are seeing a fundamental shift in healthcare delivery approach. So we are going away from treating the disease. We have been hearing this in today, this morning, and yesterday, that treating the illness is not enough. And we should be going away or thinking beyond healthcare and think about health. When we say health, health is for our population, not only when you fall sick or when our citizen or our population is sick or having any disease, rather than how to make sure that we make them healthy and keep them away from the healthcare system and make them healthy in our community. So this concept sounds quite easy, but when we are seeing this and trying to implement back in Singapore, the kind of data and information needs to exchange across the setting is like marvelous. Currently, maybe a few years ago, we were talking about integration and exchange of data and the standards, even in an acute setting. So department by department, and within our cluster, we have 3 acute hospitals, so exchange of the data from one hospital to another. But where we are today, dealing that fundamental shift of the whole healthcare delivery approach, we want to integrate the data not only from the healthcare setting, but even in the community setting. So, and then whole wearable things comes, and whole your lifestyle, the social determinants of health comes in picture, to able to know that when you might seek our help, or how do I make sure that I keep you healthy in the community and you don't need to come. So why I'm sharing like this, to just set the context and the scope and the amount of the data we need to integrate across the settings and the different kinds of data. Community data would be different than when you do a surgery in acute hospital, or when you take care of or do a rehabilitation in a step down. So this is just to set the context. There's one line we put it together, and we discussed among ourselves for a few days, is that, but what is the goal? What is the goal? So basically, anything or whatever we are trying to do, we are basically trying to improve the health outcomes and improve the patient experience, and putting the patient in the center of anything or everything what we do. So this is like a set context where we are and what challenges we have in hand and what we are set out to deal with. So Vivek, over to you.
Thank you. I'm putting the slide only as a backdrop here, because I think everybody understands this whole information overload and the conundrum that comes out of that if it is not properly utilized. Now let me kind of bring in some contextual input here. So 2016-17, we started working with the second largest not-for-profit health provider in the US. We potentially were looking at maybe 52 hospitals, about 6.7 million patients being treated. But the issue was that, the biggest problem they were facing was that when the patient moved out, having come for a particular condition, in all practical purposes, the hospital would potentially lose the continuity of care perspective as a part of that episodic intervention. And I think that continuity of care is a very interesting aspect, and maybe for whatever that we've heard this morning and from yesterday, a lot of what we are trying to influence is to focus on better health outcomes. Better health outcomes can never be done for one episodic intervention. They will always need to be carried through with the unification of data coming from various sources, whether it is genomics, as we discussed in the morning, or whether it is from the review of systems data that happens as a part of maybe your SOAP protocol that you use during your intervention at a clinic, and so on and so forth. Now, there are a lot of, so for example, if you see the progression is seen in such a way that we have built both an interpretation and contextualization through the ecosystem that we created. So we are talking about syntaxal correlation of health data across the various providers. Now, only thing that we face is that when we talk about that, are we seeing it universally being applied or utilized? And I think we're facing the challenge. I think one data very specifically states that, especially between 2014 to 2019 in the US, the prevalence of the HIEs, while the enforcement to see if they should be adopted has increased, but in real purposes, only 4.5% increase has happened, which is potentially contributing to maybe just around net of data interchange of about 13x percentage. Now, if you look at this, what are we trying to do? We are trying to get back into the same situation of the patient comes for an episodic intervention, patient comes when they are sick, and the patient never comes to a facility when they really want to see if they can prevent a situation. Now, so the second part that is interesting that we've seen, especially from a perspective of evolution that we see now, so especially with genomics coming in and we had the conversation around Dr. Ali's the metabolism and basically the cellular biology element that comes into play. I think one of the things that we have to, I think it's a proposition we put on the table, that we have the payer, provider, the pharma companies, the policymakers possibly, and obviously the patients in this room. Are we doing anything from this whole conundrum of information that we created, which is from a patient-centered standpoint? Because we do ICD codification from basically it's like a service catalog for the payer. So what do I pay for this disease type? We are never saying that, okay, how do we trace back this disease to where it emanated, and how do we ensure that we're able to kind of purge and not let it progress? Because it's not a commercially good situation to be in from a payer standpoint. From a provider standpoint, it is only information that we are collecting for that episode, because we are not looking at prevention. Because if we prevent, in all practical purpose, there's a commercial loss for me, because the patient will not come back to me if they are healthy, which in all practical purposes means that I'm losing money on it, right? And if you were to look at it from a pharma company's perspective, every time they come out with a new medicine or a new drug, it has to be commercially viable, because you spend 10 years, you spend $1 billion plus, and you need to make it commercially viable. Now, the option that we have on the table is we have this data. We have the data adoption happening. Even in a country like India, which in 2014 was about only less than 30% insured, to now almost 70%, 72% insured in terms of number of people who are insured either through government schemes or private sector. Is there a way that we can have a more cohesive payer, provider, policymaker collaboration driven on the principles of prevention? And when we do the principle of prevention, you can still keep your interests on commercial gains over a longer period of time, but you may not be able to see immediate benefits that you intend to kind of bring to the table. So I think that's a question that we have, and I potentially, Shikha, you have any thoughts on that you can actually bring up?
Yeah, so as Vivek rightly said, that the famous 5 Ps of health ecosystem, which is patient, provider, partners, as in pharmacists and medtech companies, policymaker, and payer. So when we are collecting data, exchanging data, or analyzing data, which perspective are we analyzing it from? So we all agree in principle that the entire healthcare or health should be from patient-centered approach and keeping patient in the center and thinking from a patient. But unfortunately, sometimes our policy and the payment, all this does not support the ideal concept which we think is required and putting the patient in the center. So what we have done in Singapore, and as I'm a value-based healthcare practitioner and implementing this in one of the clusters in Singapore, the Ministry of Health has implemented capitation just last year. So with this capitation model, some of the things which Vivek was trying to mention is that why are we collecting data? So when I'm collecting data, I'm just collecting the services the patient has rendered during that episode because the provider has to claim, payer has to provide, and somebody has to analyze for that from different perspective. But in capitation, what in Singapore we aim to do is to move away from healthcare and think of health. So how ministry has this implemented, and we yet to see it, it's just been 1 year. We are still trying to see that how this new model of payment and the model of care will fare out for Singapore is each cluster is responsible for an area of a Singapore. So Singapore is not very big. It's like 5-6 million people in an island. However, we have 3 clusters, which we have a positive competition. And every cluster is responsible for that area. So one cluster looks after east of Singapore, center, and another west. This is how we have done it. So in my cluster, we have to take care of 1 million of people, and we have to take care of entire west of Singapore. So when ministry is discussing with cluster and the management, what they are saying is that, oh, I'm going to give you this dollar amount for you to take care of your population. And I'm not going to reimburse based on the service. Or it's the same concept like in Singapore, we have a public insurance kind of framework. So ministry reimburses or gives a subsidy or amount of money for when we treat a patient. So now ministry has said, oh, the resource is finite and the kind of, the healthcare expenditure is increasing, I can't sustain it. So what I'm going to do is that you make your cluster efficient, you take care of your population, and I will give you this lump sum amount. And it's up to you where you pump this money. So you pump this money doing more surgery, more amputation for your diabetic foot, or you pump this money more downstream, even in community, doing screening and identifying, those diabetes which could get complicated in few months' time and prevented, or delay the disease progression rather than, just keep on reacting. It is the old way of doing the healthcare. So what we are now doing is that we are doing multi-approach to make our healthcare efficient and make sure that we keep our people healthy in the community. So now healthcare is more than healthcare. We just don't do surgery and things. We go in the community and partner with pedicure salons and all to make sure that when the citizen goes to the salon and if he has any foot ulcer related symptoms and all that, then he gets identified and you catch those things well earlier rather than when it comes that where it's rotten and you need to cut and which is like a few $100,000 when you provide their services. So what I am trying and what I'm trying to share here is that, and which Vivek has rightly said, the data exchange, interoperability and all, we are quite advanced in technology. We have been talking about it. So the technology is not a deal breaker. The deal is about the policy and governance and the regulators coming in and setting the tone that what we are trying to preach, and the payment, because the whole model revives that who has the dollar and how it's getting distributed and how it's getting different. So while our session is just about interoperability and interchange and exchange and standards, but the whole concept is maybe technology is not the deal breaker. We do have solutions and that's not a problem, but the question is that do we have a policy or regulation or the right payment model to make sure that the clusters or health data are getting exchanged in a right way for the benefit of improving health outcomes of our patient. So that's the whole thing we wanted to share with you or something. Yeah.
So I think, interestingly, I just want to kind of bring up, sometimes, as they say, charity begins at home. You can also start fairly small here and see how you can influence it. So 2016-17 in India, we covered a population of close to about 400 million people. What we did there was, we brought in 2 peers on the platform for what we call as a pre-authorization adjudication of a claim. We brought in a set of wellness centers and we codified the wellness center services so as for them to correlate and say that this service potentially may lead to, say, a ICD code which is, say, on cardiology or diabetology or so whatever the case may be. So we did a correlation between a typical cellular-based or alternative medicine-based approach as an input for a patient or as an input for an individual. I won't call it patient because the person at that point in time is still not expressing any symptoms for a disease. But maybe looking at, say, coming to us from a perspective of, say, mindful living or wellness services and so on and so forth. And then trying to see if there is a possibility for us to start mapping that into pure ICD codification from an aspect of maintaining the data. So we brought in like you may call it as like a transformation engine or a mapper, which was potentially trying to do this correlation. We started getting a lot of information about patients' lifestyle and so on and so forth prior to recommending a particular wellness program or a plan for them. So we brought in like you may call it the equivalent of a data master or a library for doing that mapping. And then we extended it further, stating that when you move from that state to some other state, we should be able to provide you a platform to interface with the right healthcare practitioner. So your choice of the right healthcare practitioner is not done through the process of a PCP, like a primary care physician, but is done through the process of what is your cellular inability that you're showing before you kind of come to maybe the treatment setup. So we changed the dimension from going to a PCP and then getting diagnosed with an issue to instead going to a wellness center and identifying what are the issues that you may have. And therefore, I think one of the things we started trying to do was, can we integrate some of the old alternative techniques, like, for example, Ayurveda or Unani, or for that matter, input coming from general soulful living wellness practitioners, and see how that can be codified into pure play medical data set. This is through a third-party independent platform, which was aggregating these services. And we then also tied it back to a peer and said that from a peer standpoint, instead of penalizing a person for giving that initial data for increasing their premiums, because finally you underwrite and you put a premium on that based on the risk profile that you've created, to saying that can you come at a stage earlier on and start looking at some programs for preventive healthcare or preventive coverage, where you are potentially only paying for the purpose of keeping the person healthy, not for the purpose of ensuring that the person is diseased and therefore you pay for the disease, right? And this has been a very interesting play for us. We were able to cover in the initial set. We started with at that point in time it was Andhra Pradesh, now it's Telangana. So basically we started from the Andhra Pradesh Telangana space, almost close to about 4 million people. 40 million people, and then we started going to some of the other regions in the country, and we started expanding it there. And when we took this program out to maybe, for example, countries like Azerbaijan or countries like now we're doing some work in Colombia and Brazil, where we have taken it to the next step and we're saying that, okay, one is the preventive element, and second is the continuity of care element through the caregiver intervention. Because a lot of times the caregiver intervention becomes also very important, because it is those people who personally interact with you after you are out of the hospital. And therefore, how do you still continue to get the right kind of information set to ensure that you're able to maintain the patient's health? Now, all this basically was leading us to, at any point of time, so like we've kind of done some, we keep a track of what we call as a set of entities. And we said that at any point of time, one single patient interaction from a wellness, soulful living analysis, all the way up to maybe, for example, if it is acute and post-acute recovery process, we were getting per patient at any point in time during maybe that, maybe whatever, it could be say a 2 years or 3 years period, over 1 billion data sets for that particular individual. And obviously, this is a very beautiful construct. If we start addressing the whole aspect of genomics now to it, suddenly the richness of data that you're talking about here will be an absolutely different level of play that we look at. And I think that's where maybe next topic that we should look at some point in time is, we've spoken about it, is we talk about generative AI and things on that nature. I believe the topic has to be driven, because generative AI normally, and I think we were having this conversation with Shikha yesterday, that a lot of times this information is engineer-driven and not practitioner-driven. Now imagine that you're able to give this information and a practitioner does the supervised learning, or rather basically enforces supervised learning for the machine, which you may call as a closed language model, for the machines to do a much better prediction. And I think maybe with that, I would want Shikha to add a few points on that, and then we'll open it for you for any question that you may have for us.
Thanks, Vivek. So yes, we were discussing about that in IT, it's a garbage in, garbage out. And sometime our data scientists and our clinicians don't speak on same languages or taxonomy. So one is talking about the wholly subject matter expertise and trying to understand how the vitals have played the role. And another is just trying to put the different types of data. Oh, let's try age, let's try Charlson comorbidity, let's try frailty, without really understanding that why are we adding that in analyzing diabetes disease progression or stroke or dementia. So this kind of things which I am seeing in my organization, that there is a bit of data exchange standard issues, and sometimes it requires a detailed discussion, and often clinicians may not have the time, bandwidth to sit with our data scientists to sit together and get it through. So that a bit here, that can be sorted out, but that's one of the things we wanted to also highlight, that in IT is garbage in, garbage out. If you don't really get the right standard, clean data, accurate data, complete data, then the whole thing may not turn out the way you want it to turn out. Another, before we open for the questions, another point I wanted to highlight is that because the goal, when we put it down, the goal is about, at the end, we want to improve the health outcomes of the patient. So when we say outcomes, there are two perspectives. One is the clinician way of looking at the outcomes. When a clinician treats a stroke patient, then he thinks is a good quality. Oh, my door to puncture time, my door to groin time, and this and that is looking at that. But from patient's point of view, maybe patients are looking at the functionality related, whether how, after a post-stroke event, how well I am going back to work if I am in the working force or society, what is my reported outcome? So sometime when we are talking about interchange and exchange and interoperability of data, we also have to see that there are few is the patient-reported outcomes. And these data needs to be integrated in our system too. And a proper standard. So currently we are we do have some standards. We have iCharms and we have some of the standards to collect it. But this could be quite different based on the settings. And how do we integrate in the longitudinal view of that patient across the episodes, across the settings, and make sense out of it. So these are some of the burning questions we still are dealing with. We didn't come up with a proper solution to share anything with you, but we are just highlighting some of the things which are on the table for us to consider and discuss.
Thanks. And I think we said that, okay, obviously everybody is in for some kind of a commercial gain. So I think as we go forward, maybe when you look at, say, a pharma manufacturer or pharma R&D entity, obviously they are expecting a better outcome of the NME that they have put on the market, and how do they get the value out of that, and so on and so forth. Similarly, it's a payer wants to ensure that they get they service the minimum amount of claims so as to be profitable, as the case in point. All the dimensions are a little contradictory from a patient standpoint, because patients looking for full coverage, good health, and so on and so forth. Sometimes I think maybe it's a good point, and if you think it is a viable point, maybe we should form, as an output of this conversation, some kind of a small working group for whoever is interested to start working and seeing if can we influence the policymakers, can we influence the ecosystem. And maybe next year, maybe if we come, or should we come here, or maybe whatever point of time, we should kind of come and say, okay, yes, we've been able to start the process of ICD coding for wellness and mindfulness living services, or neurological disorders, and so on. So we kind of start bringing those to the table and say, okay, yes, we've started influencing the industry. And I know it will not be a one-year program, it will be a longer program, but it is a program which requires all the 5 Ps to collaborate, or at least all the 4 Ps to collaborate from a benefit of a patient for a better wellness. I think I'll leave that point here. Any questions, we'll be glad to address.
Thank you very much for this conversation, very nice. I just want to put some thoughts on the ICD regulatories and whatever we are trying to diagnose a person and bringing in that particular code for maybe the insurance purposes or whatever the thing is. What I think is after this COVID has started, we need to consider COVID. It should come into the center point, because what is happening now is everybody is following the old methods of diagnosis. Everybody is trying to put the current patient into some of these coding. And it is not fitting because the diagnosis is now differential diagnosis. It cannot fit into that. And moreover, clinicians are trying to fit the person into that coding and trying to give the treatment according to that diagnosis, which is not helping anyone. So what we are seeing now, so there are a lot of my own patients who don't fit into any of these criteria. So I think ICD and all of these regulators which were there before COVID, I think they need some, rethinking of these as how we will redefine all of this coding. I think so.
A very, very good point, I think. That's why I was mentioning that maybe we have to expand the vocabulary of ICD because it is still very restricted and still very payer-centric in nature.
So I'm not a practitioner, I'm not a doctor, but I work very closely with them. So in our system, we do have few ways of coding. So we do have problem list, which is SNOMED, which is for doctors to code. And ICD is often coded by generally same purpose because insurance. And COVID does figure as one of the problem list. And when we code for the patient, this is practical knowledge I'm sharing. I'm not really coding, but this is how I have analyzed the data. One patient could have one primary and few secondary SNOMED and ICD codes. So having said that, when the COVID comes in picture, COVID is being coded as one of the comorbidity, if that is the comorbidity, not the primary diagnosis. So you could come for heart attack, and then the swab is done, and you will be COVID positive, and then you are diabetic, and then you have hypertension. So these all will be coded together. And that's how, at the end, we also calculate Charlson Comorbidity Index. So saying that where do we stratify the patient? So a healthy stroke 40-year-old is very different from a 70-year stroke, which has, the patient has hypertension, diabetes. So there are ways, and these are some of the ways we handle these things. And in addition, we also pump in the discharge summary, which is the doctor's notes, and we put the pathology, we put everything to come up with a very complicated model to see that how to stratify the patient, which risk category the patient falls in. So these are some of the ways we are trying to tackle the existing issues.
One interesting point, if you were to consider, so all of us who read chemistry read about the periodic tables. There are finite set of elements we see there, but it's a combination of them is what leads to maybe what you may call as a complex, an entity. So essentially that's where I think for us also when we started doing, so in India we are taught, as a medical science student, we are taught SOAP principles for going through the process of analyzing a condition a patient may have, but we finally end up looking at only the chief complaint. The CC becomes our primary anchor. And the second element is the review of systems is limited only to general complaints or musculoskeletal or maybe for that gastrointestinal. Now, what happens is you have to extend it beyond this to other elements like cellular health itself, because now a lot of people are talking about mitochondria dysfunctional and fatigue syndromes and so on, so coming especially after COVID. So I think what we should ideally be doing is if we can maybe form a group and create what we may call as the elements of the disease, so basically our periodic table, and then do a proposition back, I think it becomes an industry taking part in driving the policy rather than maybe waiting for the policy to happen to get that thing. That's how we kind of tried to solve that issue when we were still not, India still didn't have a health information exchange. India still didn't, at that point of time, 2014-15 time frame I'm talking about. And it still didn't have, it still had a very undercovered, insured population, We were still trying to solve this issue as a startup. So I think there is a way that we can influence the policymakers, and I think maybe if collectively we are able to take up one small initiative of this nature from this group, I think we would have achieved something out of this conference beyond exchanging ideas. Thank you.
Thank you, sir. One small question, one line to add up whatever ma'am mentioned. Actually, I'm a certified coder and auditor, so I can add some inputs to you. So as madam very well mentioned on it, yes, ICD code is periodically updated. So every year we have set of ICD codes included and deleted and also updated. So 2024, we have updated CPT code list for the procedures, and also in October we have ICD-10 codes. And as doctor said, for sure, all these COVID conditions and the complications of the COVID and even the new diseases which is arising in the healthcare, it also included in the ICD-10 codes. And already the problem is in a developing country like India, we have not yet reached that level as US. And here also in UAE, the same happens. US is very advanced and they are with the current practice of 2024, but in UAE, we are not following that 2000 code sets, and also in India also we are not following that much advanced thing. So I think these lack or gaps should be filled, so they should be doctors answered, I think, the question to the doctor's answer. So hopefully in future, these gaps will be filled, and we will be on the same advanced stage. Thank you.
So just one point, that there is a history behind why US is extensively or overcoding. Don't quote me, but this is my experience. And in India, we don't care, or it's okay. Singapore, we are just right coding because the finances are driven by that. The whole idea why we are coding is to get the reimbursement. So in US, the payers will pay you based on the codes. So the service provider will make sure that they put all your comorbidities, everything very rightfully to get the insurance money. But maybe in India, I have not worked, so I'm not sure. But in Singapore, there is an audit and we do it right, also because our ministry pays it, and the coders are deployed by the Ministry of Health to all the public healthcare institutions to make sure the coding is right, not over, not under.
So I think the difference, if you see it from a granularity of coding, you see maybe about 11,000 odd codes in India. You see about 97, 98,000 codes in the US. The reason is primarily that. The only thing is now in India, because we are trying to drive through the universal health coverage, a coverage of a minimum amount for all individuals, especially the underserved individuals in the country. You'll see something very similar happening, but obviously what we're trying to distinguish is, like in the European system, where you have to wait for so many months to get your first appointment and maybe there's your test and so on and so forth done. We are trying to still see how we can be nimble enough to get those things done, do a right merge of what you may call as out-of-pocket to maybe the payer's contribution, so as to ensure that healthcare for our patient becomes more centric, rather than maybe driven by the payer or driven by maybe any other entity. So I think at least we're seeing the right trends. We just hope the speed of acceleration is good enough for us to maybe reach a state of like a larger coverage set.
I think time's up. Maxim, we have one more question. Can we take it, or?
I'm sorry.
We have one more question.
We have to wrap it up.
Okay, so I think I'll come to you, sir. Yeah, okay, thank you.
All right, a round of applause for our speakers. Don't go anywhere. Go stand over there. I need a photo. Yes, we need photos of all our lovely speakers. Yes, big smiles. Fantastic.